Working in behavioral health or managing an organization in the industry can be challenging. Regulations are constantly changing, and staying compliant is harder than ever. That's where the Behavioral Health Association of Providers can help. BHAP is a national association for those who work in behavioral health or addiction treatment. One of the ways we serve the community is by offering educational opportunities such as CE-based webinars and our certificate in addiction treatment marketing. BHAP also provides advocacy information so you can stay on top of new laws and regulations that will affect how you do business. Our members benefit from simple, effective, and relevant resources that keep you focused on what matters most, the health and well-being of your clients. Helping small and mid-market behavioral health providers access compliance resources and legal education, BHAP is the leading and unifying voice of treatment programs. You can find out more information, as well as sign up for our various newsletters, on our website, www.bhap.us. Hello, I'm glad you could join us today. Welcome to the webinar, Building an Outpatient Referral Department, How to Serve Better Patients and Your Business. My name is Angie Fiedler-Sutton, and I'm with the Behavioral Health Association of Providers. And now it's my pleasure to introduce our presenter today. Jordan Young is the CEO of Jordan & Associates Consulting, LLC, and associate member of BHAP. He is also on the advisory team. Jordan's personal recovery and desire to help others nudged him into his career into behavioral health care. Since 2010, he's worked in positions where he helped over 4,000 patients find treatment that met their clinical, demographic, and financial needs, designed and oversaw a national conference series where he formed relationships with hundreds of behavioral health care companies and thousands of industry individuals, and provided recruiting and consulting services for startup or established treatment centers and organizations servicing the treatment industry. His core values are shaped by his relationship with God, his family, and recovery. Jordan, thank you for taking the time to present today. With that, I'm going to hand the webinar over to you.
Thank you, Angie. And good morning to everyone. So like Angie said, my name is Jordan Young, and my first job in behavioral health care, as she also mentioned, I helped patients find treatment that our facility was not the right fit for. So I worked with over 4,000 patients in that role. And that's what we're going to be going through, is how to build your own outbound referral department. So this is not going to be a lecture. I see that we have a pretty small audience here today, and I'm hoping that we can get some interaction from the audience, because I feel like it's going to go a lot better if you guys participate as well. So while I'm reading introduction here on what this webinar will discuss, can I get you guys to put in your name, where you're from, and what your facility works on, or in terms of who it treats? Oh, yeah, that's Angie. Okay. Okay, that was to the audience, not me. So if you can participate, say your title and your role and what the type of facility you work with does. So diagnosis, level of care, location, and the resources you accept from patients. So while anyone is doing that, hopefully everyone does that, I'll go over what we're going to learn and discuss in this webinar. So it'll be building an outbound referral department. So by having an outbound referral department in place, organizations will be better able to serve individuals seeking treatment, as well as patients discharging from their facilities to different levels of care. They'll also be able to create new business development relationships, strengthen existing ones, and increase inbound referrals. We're going to go into details on how to build the department from a business standpoint, but I want to state up front that the number one goal of any outbound referral is to get the patient to the facility that fits their needs. And from my experience, we can do that, and we can also do it in a way that helps our business development as well. So let's see. So we have Kathy from University of Missouri. Okay, Crossroads, San Diego. Okay, all right, KDET. Great. Building an outbound referral department. Great. So, question of why to build an outbound referral department. So, let me start by telling my story of how I got into the behavioral healthcare industry. So, I was newly sober about a year or less, and I was working in this business complex in Nashville, which is where I live. A business complex, and in that same big business area, there was a close friend of mine that worked for a treatment center organization at their admissions department. So this facility was private, so private pay, private insurance, dual diagnosis treatment for adults with facilities in a few different states. So he told me about this place and it sounded great. The work environment sounded great. I wanted to be a part of it. I wanted to kind of give back if possible, and sent my resume and told him that whenever they had something open up to let me know. So there was a gentleman who was working in their business office. He was a business analyst, so it's kind of like an IT operations type position. And this organization was generating thousands of phone calls. People were calling from all over the country seeking treatment at this organization. And because it was a pretty narrow group of people that it served, there were tons of callers that weren't able to access treatment at those facilities. So he was looking through the data, looking through the EMR and seeing all these either abandoned calls. So people were either being referred to SAMHSA, so the Substance Abuse and Mental Health Service Administration, to their treatment locator to continue the search on their own for treatment, or the file was just being closed and there was no callback. So that gentleman, and that is his name, but that is not actually a picture of him. So Kay, what he said was that we have a responsibility to help every person we market to. We're dropping the ball by not helping these patients that are seeking treatment with us. Even if we're not directly helping them with treatment at our facilities, we need to be helping them in some way. So let me ask the audience, if you guys can participate, what are you doing for callers that your facility is not appropriate for? Now, this is a rhetorical question, okay? So there are a few options. Do you give them the phone number to a website or a directory to start over the search elsewhere? Do you just not call them back, or do you call them back and you just simply tell them that your facility is not going to be the right fit for them? Or do you refer them to a facility that's maybe on a short list of resources, which may not be the right fit for this person's need? Another option is perhaps you refer them out to a facility, but then after the referral, you lose track of what happened with them. So if any of these sound familiar, you are not alone. That is the case with many organizations. I apologize, I'm toggling between two different monitors here. Okay, so what are the goals of an outbound referral department? Okay, there we go. Rachel, get their authorization to help them find a place for their needs and insurance and call the patient back with their needs and connect them appropriately. Great. Yeah, that's exactly right. Great. So the goals of an outbound referral department. So providing patients your facility is not the best fit for with an option that fits their clinical, financial, and geographic limitations. So clinical, so each person is different and their needs are different as well. So just a personal story, when I first started working in this outbound referral department, I'm a 12-step guy. 12 steps is what got me sober. And whenever I heard anyone talk negatively about a 12-step program, it made me really frustrated. I was thinking, well, 12 steps work for me. They can work for you as well. Well, just taking a step back years later, I realized no, because this worked for me, that doesn't necessarily mean that it's going to work for everyone. So finding a facility that fits each individual person's needs and their individual story and their clinical needs. That's the first step. The second step is financial. So insurance to a large degree is determining the appropriateness of a particular program for individuals. So let's say, for example, you have a patient that your program is going to be a perfect fit for clinically. Your facility is a trauma intensive program that's geared towards women that also struggle with alcoholism. And that's exactly what this caller is. So the facility you represent is a private pay or private insurance program, meaning those are the individuals that gain acceptance into your program. And it's out of network, so no in-network contracts. Now, this person who's calling in, they're a great clinical fit. They have private insurance, but it's an HMO with Cigna. And that is not a fit for what your program accepts. And your $25,000 monthly private pay rate is outside of their financial means. So we need to find that person a financial fit. What about geographics? So outpatient treatment needs to be local to the person seeking treatment. I think we can agree on that. One thing that I am a big fan of myself is people going to residential treatment outside of their home environment. My personal belief is many people are able to focus more on treatment when they go away due to being less likely to leave AMA. If they're in their home environment, they're closer to family, to friends, to triggers. But sometimes local treatment is the only option for people, like I stated, for outpatient, but there are insurance restrictions that do not allow people to leave the area. So we need to be aware that geographically, we're going to have limitations at times. Another reason to look into an outbound referral department is to find out what other people are doing, to get a pulse on the industry. Oh, and going back to my prior slide, I apologize. Developing new reciprocal relationships. That's a big one. So developing the reciprocal relationships and supporting your business development team. So for example, the program that I represented, it was high-end dual diagnosis treatment for adults. We had some in-network private contracts, but we couldn't treat everyone. So a few examples, if we had callers with Medicaid, we had Medicaid patients that were seeking treatment in California. Maybe they had the combination of Medicaid and Medicare. There was a program that we would refer to that was a great fit for those individuals. Now, this was a reciprocal relationship for us because when they had people seeking dual diagnosis treatment, individuals that had private resources, they would send to us. Another example is an adolescent program. We did not serve adolescents. We served only adults. There was a high quality adolescent program for substance use and some light co-occurring. They were a great referral partner for us because they could help these adolescents, but also if they had people that needed heavier mental health treatment than what they provided, even though they treated adults, they were very light with the co-occurring. They would refer those heavier co-occurring or mental health primary patients to us. Another example, program very similar to our own, it was a dual diagnosis program that was in network with Aetna, kind of mirrored us, but when we had people that had Aetna HMO policies, which we were not in network with, they were a great organization to refer to because one, they fit their clinical needs, they fit their needs for their resources, but they also would refer patients back to us who had similar needs but had a Blue Cross Blue Shield HMO policy. Now we were in network with Blue Cross and they were not. So this was another great reciprocal relationship. Then again, like I stated, for competitive reasons, it's great to have an outbound referral department just to know what people in your area and people around the country are doing. So when you're considering expanding into a new service offering or a new geographic location, it's awesome to have this type of information. Now, how to structure the outbound referral department. Okay, there you go. Sorry, reading the chat. All right, so how to structure your outbound referral department. Now, there's a few questions that we need to ask here. So what does your current staff have the bandwidth to research? Does your current staff have the bandwidth to research facilities and build a database? So we're going to need a database here. And we'll go a little bit more into that with the CRM and doing the search with that CRM. But looking at how to structure this team, what does your current staff look like? And who's going to do the heavy lifting here? So these questions, does your existing admissions staff or the other staff that you have, do they have the bandwidth to put in the time it takes to research facilities, build the database, and either call patients back or spend the time on the phone with patients, giving them that referral? Another question is, if the people taking the initial phone calls are also doing the outbound referrals, how much time is that going to take away from the other potential admissions calls that they could be answering? And say that they are missing potential admissions calls, how likely is it that those calls are admissions that are dropped? Another question to consider is, will you have enough staff to keep the admissions counselors on the phone with these patients and not miss the calls? That kind of hit what we were talking about in the prior question. Last question is, if you choose to call patients back to give them a referral, regardless of whether it's the admissions coordinator or it's a designated referral agent, how quickly do you want to ensure that patients receive their call back? So anyone that's worked admissions before probably knows that the longer it takes to call someone back, the more likely it is that they're going to find another resource or that you're not going to be able to get them back on the phone. So I know that our goal whenever we were doing the referrals was within 24 hours to call someone back. Does anyone here have any sort of requirements or any guidelines of when they try to get back with admissions, potential admissions callers? Is it same day? Is it within an hour, 2 hours? We'll just let you guys. I think if an hour, that's great. The quicker the better. And if you're using something, if you're private and you're using an instant insurance verification service, that's excellent. Because I know that one of the problems that would slow down the ability to call people back more quickly is if you had to go through a full verification of benefits process. Okay, so where to find the right facility? Okay, let's start with where we begin our search when we're looking for facilities. with a specific referral in mind. So this, or if we're just simply trying to build a database so that we can have resources on hand so we don't have to constantly do a search every time we have a caller with a position or in a situation that may be unique to what we've experienced thus far. So there's a lot of directories out there that you can go through for building out these referral databases. And the directories are a great place to start, but I never suggest making a referral based on what's on a website. These directories that you can seek organizations out at, they're great for finding the places that ideally you want to call. You want to call and uncover information on the program. So a couple that we'll talk about here are NATAP and SAMHSA, the SAMHSA treatment locator. NATAP, as of, this was about 6 weeks ago, there were over 1,000 programs listed, and there was more criteria that you could search within NATAP than with SAMHSA. I was actually pretty surprised at all the different options that you could search with NATAP, but you look, it's 20 times 20 times fewer the number of listings as you have with SAMHSA. But SAMHSA has fewer search options whenever you do find them. Okay. All right, and Angie, BHAP has locatetreatment.com. Needed. Oh, sorry, you're leaving, Linda. Thank you. Now, Angie, how many do you know how many programs are listed at the locatetreatment.com option?
LocateTreatment.com is actually run by Get Help, which is, it also posts the listings there as well as on CCAPs and counselors things. I want to say anyone can claim a listing. I want to say, I don't know off the top of my head how many are there, but it is something that we've been trying to, it's relatively new that we've been pushing this. So that's why I figured I'd throw it in there.
Oh yeah.
BHAP
No,
members
that's
are given a little seal that indicates that they are BHAP members, so therefore they follow our code of ethics, which helps people who are searching for it as well.
great. Yeah, and there's another, locatetreatment.com. So these are great places to go, like I mentioned, to find organizations that ideally what you're going to do is you're going to dig into the organization and specifically what they do, the demographics that they serve best. All right, next up, what data do we need and how do we house it? Or maybe where do we house it should be the way we put that. So say that we have the directory or 2 or 3 that we want to work with that'll help us find these facilities that we reach out to. Now, what information do we need from them? What's going to help us determine what's going to be an appropriate referral for an individual and not? So some necessities I think that we should find out from potential referral facilities. And if I'm missing any here, please feel free to type them into the chat. But location, level of care, so detox, residential, outpatient, telehealth, sober living, with length of stay for residential and sober living if possible. Accreditation, so Joint Commission, CARF, any other accreditations. I'm not aware of any others besides the local states, but if there are other accreditations, we would have those listed as well. Facility type, so that's freestanding facility, hospital-based facility. I know in the past there were a lot of insurance restrictions requiring that people seek treatment at hospital-based facilities. Ages and gender served, so this could be co-ed, gender specific, female only, male only, etc. Type of treatment provided, so substance use primary, co-occurring, mental health primary, specific process addictions. That's an important one. Type of treatment provided. No, we just said that. Insurance is accepted. So this one is very important. So we can list out of network, we could list private pay, Medicaid, TRICARE, Medicare, and then in-network insurances. Being able to select the different in-network insurances is going to help us greatly whenever we have someone who calls in that has maybe an HMO policy for a type of insurance that we're not in network with. Then finally, private pay rate. Oh, no. Sorry about that, guys. Okay. Okay, I'm gonna move my mouse. There we go. So I know that calling and requesting all this information from someone, it's kind of like you're interrogating them. And well, if you're on the other end of it, but explaining to people whenever you call them that the reason you're seeking this information is so you can make appropriate referrals to that organization, that helps sometimes. I remember one particular story. I was calling, getting all this information from an admissions director who I understand this was a busy guy, running the admissions department. And so I started asking about the in-network insurances. And the guy told me, we're network with everyone. I said, okay, what about Blue Cross or MHNet or ComPsych? He's like, yeah, in network with all of them. And then, probably not my finest moment, but because he either didn't have the time or didn't have the patience to go through a thorough list with me, I started naming off really obscure insurances, which he said, no, no, no. I ended up apologizing to the guy, but explaining to people why we need this, that's really important, I think, because if they understand that the reason that you're doing this is to help make referrals to their organization that are going to be appropriate, that can be beneficial. Now, another option, instead of having them do this on the phone, is to put together basically a worksheet that asks all these questions. You can send it over to them for them to fill out whenever they have the time. Now, if we have audience participation, is there anything else that we're leaving off here that you feel would be vital information to get from a potential referral partner? Maybe if it like transportation provided or transportation assistance, maybe things like that. So if you want to type it in there, if you have feedback, great. If not, I'm still going to continue on. All right. So other factors. Let's see. So we need to decide what CRM to use. Yeah, if they have disabilities, that's great, Angie. Okay, so some factors. So the CRM, that's really important. I used a few during my time, and I know that criminal history. Okay, yeah, that's good to know. If the facility, well, I guess accept patients that have a criminal background, perhaps. Yep, smoking. Yep, that's another one. Left off smoking. Yeah. So these types of things. So these are the types of questions that we want to ask and have listed in our database, so that maybe someone wants a facility that does not allow smoking, or they have to have smoking. Or another one is technology. Some people have to have their laptop. Some people have to have their cell phone. Some people have to have their pet. So those could be other questions that we could ask. Now, as far as where we house all this information, we need to find a CRM. Now, CRMs, I know that Lightning Step has a CRM. They also have an EHR and a billing component that's convenient. Keepu does the same. Everyone knows what Salesforce, For CRM, I personally use HubSpot because it's free. So CRMs, some things to consider when deciding what CRM we're going to use is how easy is it to sort the parameters. And when I say parameters, I mean just the different categories that we were going to ask the facility about: the location, levels of care, whether they allow smoking. Okay. And for organizing in on HubSpot, Rachel, I do not know that. I use it for my consulting business. Honestly, I couldn't tell you how to organize it on the platforms that I used, which were Salesforce and LongJump. I could tell you how to do it, but I couldn't actually tell you how to set that up. But how easy is it to customize this? So how many parameters can we have in on a search? Do the searches save after each individual account is viewed? So one of the CRM systems that I used that I used, it would reset every time after you clicked in an account. So you do a search that has 7 different parameters, 7 different categories that we're searching, and you go into the first option and say you look at the information there and that one doesn't look like the place you want to refer to. Well, it would reset. And then you have to go back through that whole process again. It was very, very inconvenient. And it slowed down productivity, and it was something that, had I been the one making the decision at that time, I would have not used that. So any experience any experience with doing this from the audience? Any CRMs that you use for accounts, referrals? If not, we can move on. Then we shall move on. Okay, so when and how to make a referral. I feel like there are different types of referrals. There are quick referrals. These are patients that you instantly know that your facility does not fit. So these could be people that their insurance is not going to be a fit. It could be a Medicaid, a TRICARE, a Medicare. It could be an adolescent. It could be an age group you don't serve. It could be an adolescent, or if you're an adult only program, or an adult if you're an adolescent only program. It could be a mental health primary patient. It could be someone with an HMO for a type of insurance that you're not in network with. So quick referrals are your go-to places that you have a list of, you make frequent referrals to, and ideally while you're on the phone with the patient, that first call, you can make that referral. Assuming that they're the right clinical fit for the for the patient. Different category is patients that you think your facility is going to be a fit for, but you later find out that it's not. So these could be good clinical fits, but then you find out later that insurance coverage isn't adequate for your services, or it's someone who you think could be a clinical fit. Maybe you run it by someone at the facility and they say that your facility just is not going to be the right fit for them, maybe for their mental health acuity. So these people, another group of people, is folks that you think it's going to be a clinical fit, but the insurance coverage is not adequate. I think I just mentioned that, but these can either be people that you call back quickly. You can maybe do it while you're on the phone if you use Verify TX or Instant VOB or another one of those services that will check the insurance while you're on the phone with them. But say that you have to call the patient back after going through a full insurance determination. Um, my experience has been that being able to have the referral facility contact the patient, they're going to connect a lot more frequently than putting the onus on the patient. What about getting them connected? Okay, yeah, I just kind of jumped into that. But you can do direct transfers. That would be with the patient on the line. You get their permission to connect them with the other facility and transfer that call, or with their permission, you have the facility contact them directly. So this is a case, and I advise people speak with your attorney first before you decide your organization's path for doing this. So this is in regard to HIPAA and what information you can share about the patient with the other organization. So I actually got a quote from Harry Nelson. So Harry Nelson is a partner at Nelson Hardiman. They're an experienced law firm that specializes and focuses on behavioral health care. I asked Harry about getting an authorization from callers prior to sharing their information, either verbally or sending it to the facility that you're referring them to. And Harry's response was, technically, you don't need to get a signature, but you do need to provide the patient a notice of privacy practices, which tells them how you'll use and handle their information, which then authorizes you to use it further for purposes of treatment, payment, operations. So bottom line, Harry said, you don't need an authorization, but it never hurts. So my next question to Harry was, is it okay to tell the facility about the patient's situation without providing identifying details prior to their call with the referral facility? And can you transfer it? Harry said if they signed a notice of privacy practices, this would also legitimately qualify as operations function authorized by the NPP, the Notice of Privacy Practices. So Harry's advice is provide the notice of practice of privacy practices. I apologize. But before formalizing your decision again, I would consult with your attorney. Okay, following up. So why do we follow up? And that's not a question that is intended to be insensitive. It's a real question. It's asked from a business standpoint. Why do we follow up? Why do we follow up on these referrals we're making to other facilities? So a few of the reasons are this ensures that the facilities that we're referring to, that they know about the referrals you're making. This ensures that the referrals you're sending out are actually making contact with the admissions staff, or the admissions staff is actually making contact with the patients you're referring. And this can help you identify reasons why contact is not being made. It can help you to identify that the contact information you provided was not correct. You can rectify that. Another reason to follow up is it ensures that the patients we're referring to facilities are going to be the right fits. So we're able to make more appropriate referrals to facilities when we know what an ideal patient looks like for that facility. And if we know reasons why some referrals that we sent were not appropriate for that facility, or why that facility was not appropriate for the patient, that's going to help us better understand how to be a good referral partner to them and how to direct patients to them that would be an ideal fit for their program. And again, I would suggest speaking with your attorney about following up and providing some legal advice on what's okay for you and your organization. Okay, engaging with other departments. So how does our new department, our new referral department, engage with other areas of our business? So let's look at the business development team. So in an ideal world, the business development team and the outbound referral department or the admissions department are going to work hand in hand. They're going to be cohesively working together to identify potential referral partners. So regular contact between those two departments is vital. Both the outbound referral department and the business development team were able to identify facilities that can help patients that our facilities do not treat, or our facilities do not serve best, rather. So through the screening of the admission side of things from the referral team to actually seeing the facility, meeting the staff and the clinical team from the business development side of things, we're able to work together and discuss feedback from these interactions that'll help us identify referral partners that make sense for our organization. So thinking back to my time as an outbound referral agent, I remember two BD reps that we had that were head and shoulders above the others in terms of their work with our department, the way that they used us and worked together with us. And we were working cohesively together. And it's really not surprising to me that these two individuals have thrived in VP and director of business development positions for years now. So they used the resources, the team that was available to help them, available to them to help them. So another way to work with the business development team is go over past referrals that you sent out. So if you're seeing that this is a one-way referral relationship, we should maybe start to seek out other alternatives and seek these referrals to other potential partners, assuming that those facilities serve the same type of clients and provide treatment at the same quality, the same quality level. So what about engaging with the insurance department? It's great to know why certain insurances do not work with your organization. It's also a great way for your organization to help determine who you want to go and network with, if you want to go and network. You can change your marketing campaigns or shift your strategy based upon what you're seeing from the insurance department. Marketing department. So your CRM and your EHR can help us keep track of highly important data. And that data is going to identify the origin of phone calls. So if we have a CRM and we're logging the origins of our phone calls, either internet calls, business development leads, alumni referrals, social media calls, it should be pretty easy for us to measure what's working for our organization and what's not. And we can adjust our strategy here based upon what we're seeing. So for example, if we're spending a lot of money on digital marketing for SEO and PPC campaigns, but we're seeing few calls that are yielding admissions for our organization, maybe we want to look at shifting some of those resources elsewhere. Or maybe we're seeing an adequate amount of social media calls or alumni calls, but limited resources are being spent in those areas. Perhaps we want to look at shifting some of those funds from digital to those areas. And final thoughts here. So we've talked about many things with building an outbound referral department. So this could be a much more of an investment of time and financial resources than your organization wants. But it doesn't have to be this sophisticated, or as some of you may say, as unsophisticated as I've made it sound. But either way, it doesn't have to look like this. It can be as simple as having one referral agent or an admissions counselor that serves a dual role. Even if it's just the one person and a formal department isn't created, some piece of this could be utilized to better serve your organization. Another reason that we can consider investing in building an outbound referral department is that we've chosen this line of work. This is the careers that we have chosen. Hopefully, we've chosen. And we know more about it and the players within the field than the general public does. And unfortunately, a lot of us will see people go from one failed treatment experience to the next based upon whoever's at the top of a Google listing. So I have someone very, very close to me who a few years ago I helped get into treatment. And this was this person's probably about fifth time in treatment. And she was going to programs that were good, that had pretty good reputations, but they weren't working for her. And what she said to me, I'll never forget this quote, was, if this is the solution and it doesn't work for me, then I must be beyond repair, or I must be beyond help. And what the problem was while she was going to good programs, those weren't the best programs for her individual situation. This person, not only did they need their substance use addressed, they needed something that was heavily trauma intensive. And I was able to see that, and knowing as many good programs as I've been lucky enough to establish relationships with, I had a very good one that fit her needs for substance use, for trauma, her financial needs, and referred her there. She's been sober for several years now, totally transformed her life. And I think that had she gone to another program that did not adequately address that trauma, she may still be involved with that revolving door. So maybe it's not as simple as what we just went through, but there are ways that we can serve patients that our facilities do not directly serve. And if we do this correctly, we can help our business at the same time. So with that, I hope that our time today has helped any of you that may be considering this service. With that, does anybody have any questions?
We have about 10 minutes left, so if anyone also wants to come on camera and talk a little bit, we can make that happen. But I have Jordan's contact info on the front, so up there, as well as BHAP's information, should you want be interested. Excuse me. I had a question and then my brain just blanked. It has been a day. What would you
You're
say?
welcome,
What would you
Rachel.
say
Thank you for.
is your number one thing that people should keep an eye out? I mean, you gave a lot of tips, but what's the main thing they should be taking away?
I think that I think that knowing that that we're entrenched in this. This is our career. You know, we know more than the general public does, and if people are seeking treatment with our organization, even if we're not the right fit, hopefully we're passionate enough about this field and about people in general to help them find something that is going to be a better fit than maybe what they could find on their own. We're a lot more likely to be able to help someone find an appropriate resource, then they probably can on their own, because this is our line of work. This is our career.
Joseph wrote that he knows working with Wyoming corrections being scarce with resource, it's hard to get treatment or even housing for violent offenders, sex offenders to receive continued treatment. I didn't know if you wanted to, if you had anything to add to that.
Yeah, that's a tougher one. That is a tougher one, and that would be something that, when seeking out facilities, that's another one of those categories that we could list. Yes, for sex offenders. Um, and as we're doing our searches, I mean, if that's what someone needs, we literally can just click a box in Salesforce or HubSpot or Lightning Step or Kipu and add that criteria, because yeah, like you mentioned, Joseph, that's tough.
Okay, any other questions? Um, Rachel was unfamiliar with BHAP. We are a national organization for people who are in the behavioral health and addiction treatment industry. We offer up advocacy information, compliance information, CE-based webinars, although this one is not offering a CE, although it is eligible for our CATM, which is the Certificate in Addiction Treatment Marketing. It is a 6-course program that basically teaches you how to market your program ethically. We have everything from, how to social media and how that interchanges to it, to print ads and other stuff. I've actually been redoing some of our website for that, so I'm a lot more familiar with it than I had been. And so that is definitely a great resource. Anybody who has attended here will get a coupon for 10% off one of the 6 courses. And then, of course, you have to renew it every couple of years. And this is one of the courses that will be eligible for renewal on that. If you have any other questions on that, you can find that on our website at bhap.us. Jordan, are you familiar much with the CATM? I'm trying to remember.
Yes, I'm very familiar with that, but I'm also familiar with that amazing that amazing training. What is it? A 10-part training for the startups.
Oh,
I've recommended it to several of my startup clients.
yeah, the SUD boot camp.
Yes.
That is
Yeah,
a
the SUD boot camp provides information, I mean, basically for someone that has no experience in the industry, they could have come in with very limited knowledge, and it's like a what is it, the quick notes books.
yeah.
It's like
Oh,
that, but I
maybe.
mean, it hits everything: operations, insurance, and it's really really good.
I want to say it's 11 webinars in total. You can obviously take just one or all 11. The first one is free, and that is kind of a teaser slash taste of the rest of the workshops. It's Harry Nelson, who you had quoted before, kind of giving a brief overview of what you can see in, 10 tricks, I think, of running an SUD business, and it basically is a way of saying, hey, if you like this, here are the other 10. If you do buy all 11 at once, you can get a discounted price, but again, you can take them just one at a time as well.
It's like Cliff's Notes. That's what I was looking for.
Okay, well, looks like we have no questions with that. I want to thank Jordan Young for presenting today. Thanks as well for you for participating. A reminder that you will be receiving an email in the next few business days that will have information on how to access any information about this webinar. It will be coming from at bhap.us and sometimes winds up in spam, so make sure to keep your eyes out for it. We hope you join us for future webinars. Currently, we don't have anything on plan, but we are participating in the California Addiction Conference with the National Recovery Capital Conference. It's kind of a combined, it's one of the 4, they're doing 3 different conferences at once, where we basically are talking about recovery capital all day. If you want more information about that, just email us. You can respond to the email that we send out here in a week. You can also sign up for our website various newsletters, which includes emails specific to upcoming events at our website, www.bhap.us. With that, this concludes today's webinar. Thank you very much.
Thank you, guys.